Hello everyone, welcome to Columbia Health Talks, Columbia Hospital, Satrapur Road. In this session, we have with us Dr. Sampath, Senior Consultant ENT and Skull Base Surgery, Columbia Hospital, Satrapur Road. We have received and are still receiving a lot of questions from our patients and people viewing, and I will be putting across the most popular questions up to Dr. Sampath. Dr. Sampath, welcome.
Thank you.
So Dr. Sampath, I think skull base surgery is something very new. And what is skull base surgery? Could you tell us a little about it?
Skull base surgery is a group of surgeries that are performed to remove diseases in the skull base, which is essentially a territory that's shared between the neurosurgeons, the ENT surgeons, and the head and neck surgeons. So I would put it as 1/3 of the territory is intradural, that is inside the brain. 1/3 of the territory is in the bone of the skull base, that is the temporal bone and the petroclival areas, occipital-petroclival areas. And the other part, the other 1/3 is in the upper neck, also called the upper parapharyngeal space. So any disease that involves or transits between these three areas is essentially called the skull base, and surgeries for diseases in these areas called skull base surgery.
So are skull base tumors very common?
In fact, on the contrary, skull base tumors are very rare, and that's why gaining expertise in a specialty like skull base surgery becomes difficult, because it's difficult to find one big center where a lot of cases are done routinely, and it's also difficult for the patients, because since these are rare tumors, they have to also seek centers or doctors who have had certain degree of expertise in dealing with such tumors. So yes, they are rare tumors, and that makes treating such tumors fairly difficult.
So how will a patient present, if at all, with a skull base tumor or a skull base disease, if I could call it?
Yes, skull base diseases, not all skull base diseases are tumors. So tumors form a part of the spectrum of diseases in the skull base. There are a lot of other infectious lesions and congenital lesions that could prop up in the skull base. But skull base diseases present quite late because of the fact that they're deep within the face, the head, and in a very closed area. Hence, symptomatically, these patients present quite late unless the tumor is very close to one of the nerves. And that makes treatment also difficult, because we would then be dealing with a fairly big lesion which has accumulated itself over a long period of time. But if you ask me what are the symptoms usually are symptoms related to the ear, eyes, nose, or the brain. So these patients could present with hearing loss, facial nerve paralysis, trigeminal nerve symptoms like pain of the face, symptoms of the lower cranial nerves like vocal cord paralysis, tongue paralysis, swallowing difficulties, and shoulder issues. They could also present with vision loss, headaches, seizures, and other neurogenic problems.
So doctor, how are these patients managed? Or, maybe I should ask you the question, what are the modes of treatment of these patients with skull base disease?
Essentially, there are three modes of treatment for skull base tumors. One is to do nothing and to just wait and scan these patients. Some of these patients with very small tumors which are located close to important structures could just be, especially in elderly patients, could just be waited upon by doing serial scans every 6 months or a year. Some of these tumors grow very slowly. They don't need to be operated upon or treated invasively. So that's one of the treatment policies that we employ with some specific tumors. The other solution is radiotherapy. Now, radiotherapy is given for malignant tumors as well as some of the benign tumors. because some of these tumors are locally aggressive, and some of these tumors may not be amenable to surgery, or they may be in areas which are not amenable for surgery, or where surgery would probably cause more damage due to the fact that there are so many nerves and so many important blood vessels and other structures going across the skull base. So collateral damage could be much higher than the tumor itself. So in such cases, radiotherapy could be preferred. Yes, there's surgery. There's always surgery. Surgery is the mainstay of treatment for most skull base tumors, and there are many ways to go about removing tumors in the skull base.
So if we talk about surgeries or skull base surgery, it's, do we consider it to be a major surgery?
Skull base surgeries are usually major surgeries. They require general anesthesia, and they go on for several hours. Most surgeries for tumors are quite long. They can go up to anywhere between 6 hours to 12 hours. In fact, even more. It all depends on the location of the tumor and the way it has infiltrated or involved important structures like the internal carotid artery. In fact, the internal carotid artery and the vertebral arteries are the two most important structures which supply blood to the brain, and we need to be very careful about how we manage these vessels. And any tumor that's engulfing or infiltrating these structures, or also the nerve of the eyes, the optic nerve and other cranial nerves, all this requires special attention, and this makes surgeries of the skull base quite a prolonged affair.
So doctor, could you tell us that with so much of advancement in the medical field or the surgical field, can skull base surgeries be made minimally invasive?
Surgeries of the skull base, in fact, have become minimally invasive in the last couple of decades. Let's take the example of pituitary adenoma, for instance. So, the tumor, which is located bang in the middle of the skull base, is now removed through the nose using an endoscope and a camera and a variety of tools, including neuronavigation, neuromonitoring, and all these things. And these tumors are safely removed, even if the adenoma is located between the two carotid arteries. They're safely removed through the nose, and almost any size of pituitary adenomas can be removed through the nose using an endoscope. And this is what we call transnasal anterior skull base surgery, endoscopic anterior skull base surgery. Similarly, there are a lot of other examples, transorbital approaches, retrosigmoid approaches, suboccipital approaches, combined approaches, which have made removal of tumors minimally invasive, and this is to everyone's benefit, and especially for the patient.
So, like as you told us, the skull base surgeries are, take a long time. They are over a prolonged duration. But what about these minimally invasive surgeries? Do they also take the 2 to 3 hours or 2 to 4 hours, or what will be the time duration?
In fact, the more minimally invasive a surgery becomes, the longer it takes, because it needs that extra bit of attention, and we are dealing with the tumor, with the same tumor vis-a-vis an external approach. We are removing the same tumor in a very narrow space through the two nostrils, for instance, or through the ear, or behind the ear, or above the eyes. So these are approaches that require a high degree of expertise, skill, concentration, and that makes and of course instruments. We need new neuronavigation, a plethora of instruments to make it safe. So minimally invasive surgeries doesn't necessarily mean that the surgery takes a shorter time. In fact, on the contrary, they take a longer time.
So you just mentioned about special equipment. Could you just tell us a little more about the types of equipment required for such surgeries?
Most of the surgeries in the skull base are equipment dependent, and that's what kind of adds to the cost of surgery as well. Since most of these tumors are seated quite deeply in the middle of the head, in the middle of the face, these tumors need special tools. And when I say tools, I'm not only talking about cold instruments, which are essentially used by the surgeons to remove the tumor. And these are all specialized instruments designed to go through very narrow areas, but also in terms of equipments like neuronavigation, neuromonitoring, and also neuroanesthesia. We require a very highly sophisticated form of anesthesia to make sure that the patient is safe. So yes, skull base surgery is equipment dependent, and we need a lot of good equipments to perform some of these surgeries.
So coming to the rehabilitation options, are there any rehabilitation options for people with nerve deficits either before or after skull base surgeries?
Yes. When there are tumors in the skull base, they're very close to nerves, or they rise from nerves. And a lot of times the tumor would have already caused a paralysis of one of the cranial nerves by the time the patient presents to the surgeon. In addition to removal of the tumor, it is also important for the surgeon to be able to restitute or restore the functions of the nerves as much as possible. Hence, yes, there are many rehabilitation options. If we were to talk about rehabilitation of the hearing nerve, the cochlear nerve, which is often damaged or involved in vestibular schwannomas, meningiomas of the cerebellopontine angle, and almost every tumor of the cerebellopontine angle, then we can talk about cochlear implants or bone-anchored hearing implants, which can be done either simultaneously or can be done in a second sitting after tumor removal. Similarly, the facial nerve is a very important nerve, and which tends to get affected when the tumor lies somewhere in the temporal bone, and this has to be rehabilitated because a paralysis of the facial nerve can be quite devastating to the patient. So again, restitution of the facial nerve can be done either in the same sitting during the primary surgery or after a few months, and there are a lot of protocols that we have laid in place to make sure that the nerves are also rehabilitated after the primary surgery.
Doctor, could you tell us the most common diseases encountered in skull base?
Yes, the diseases of the nose, the anterior skull base would be pituitary adenomas, craniophryngiomas, esthesioneuroblastoma, juvenile nasopharyngeal angiofibromas, inverted papillomas, malignancies, squamous cell carcinomas, nasopharyngeal carcinomas, spinopetroclival meningiomas, orbital lesions, optic nerve lesions, and CSF leaks, cerebrospinal fluid leaks. In the lateral skull base, I would say vestibular schwannomas, tympanojugular paragangliomas, tympanomastoid paragangliomas, again posterior petrous face meningiomas, CP angle tumors like epidermoids, and there are many tumors which are very rare, and most of these tumors need to be removed by surgery.
Dr. Sampath, you are one of the few doctors extensively trained in lateral and anterior skull base surgery. So how has your personal journey been with skull base surgery?
I left India about 7 years back in search of, in my pursuit to learn skull base surgery. I did my joint European diploma at the University of Paris in anterior skull base surgery, and then my European neurotology training at Gruppo Otologico. And both these centers are one of the renowned centers in the world for skull base surgeries. So I spent 7 years in Europe training myself in both anterior and lateral skull base surgeries. I was with Professor Mario Sanna, who is considered as one of the most important surgeons in skull base surgery, and I trained directly under him. I was a part of his group for close to 7 years. After my fellowship with him, he took me as a part of his group, and I worked with him as a colleague for about close to 5.5 years. And yes, it has been a fantastic journey. I never expected, when I set out from India, I never expected to stay so long in the pursuit of of honing my skills in skull base surgery, I should say. But it's been great. I've been privileged and honored to be trained by some of the best names in skull base surgery. I've met almost all top skull base surgeons in Europe and in the Americas and in Asia. And I've had the privilege to train under 3 or 4 of them very extensively, and it's been very good. And I've now come back to India, and I hope to put my training and expertise to good use here and serve the people of this country.
So where do you see skull base surgery go from here, and what is the future of skull base surgery?
The future of skull base surgery is very bright, and in fact it's one of those nascent fields or subjects that's making huge strides. We are reaching deeper and deeper into skull base. Surgeries of the skull base in the past were fraught with high mortality and morbidities, but those have been brought down drastically to sub-0 percentages. The equipments like neuronavigation, neuro monitoring, and a variety of tools, including lasers, cobblators, and the CUSA, for instance, have really changed the game in skull base surgery. Skull base surgeries will only go ahead to be more safer and more minimally invasive. That apart, robotics is making a big entry into skull base surgery. In fact, I am in touch with a robotic company from the Netherlands, and we are working together. Eindhoven Robotics is one of the top robotic companies in the world, and they have come out with area-specific robots, and we are working in close association with them to develop robots for skull base surgery, and this is a work in progress. And with the introduction of robots, it only has to be more minimally invasive and more accurate, and this is an area which is very exciting. So the fact that most of these tumors are in close proximity to several nerves, arteries, and veins, and the brain, of course, means that something like a robot which can be very precise and which can be very minimally invasive can only be a big boon to skull base surgery. So that's the way forward.
So you have done many unique cases here at Sajapur. Can you tell us about one such complex case done here?
Yes, we've had good results with skull base surgeries. We've had a series of complex cases, I would say, and almost all of them, as far as I remember, have done well. We've not had any major failures, I would say, at Columbia Asia. But there's one case that comes to my mind. There was a young patient who was married a while back, and subsequent to marriage, he was diagnosed to have a tumor, a massive tumor, a tympanojugular paraganglioma, which was a huge one. It was one of the biggest tumors that I had seen in my career. And this patient was treated elsewhere in the beginning, and then he came to me, and I saw that it was a difficult case. But to make matters a little more complicated, his wife was carrying as well, so it was a little hard, I would say, to make sure that this patient came out of the theater well. We did an extensive surgery. I think it took close to 12 to 14 hours, and we managed to remove most of the tumor. There was a little bit of a tumor on the dura, which was intentionally left behind in order to prevent CSF leak. But this can be easily removed in a second sitting, or it could also be subjected to radiotherapy. In effect, this has been one of the most difficult cases that we have done at Columbia Asia Hospital, Sarjapur Road.
Thank you, Dr. Sampath, for taking us through skull base surgery and the most common diseases encountered, and also the management of skull base diseases. Thank you very much.
Thank you. It's been a pleasure. Thank you.